You are a doctor or a midwife or a hospital manager, and you are wondering whether caesarean sections are performed appropriately in your healthcare facility. The QUALI-DEC project provides several tools to check the relevance of each caesarean section indication in relation to the clinical protocols you use in your own department. If you do not have any clinical protocols, you can use the ones we have made available on the QUALI-DEC project website. They describe, in the form of decision algorithm, the management of the most common obstetric complications that cause a large proportion of caesarean sections, such as abnormal fetal heart rate or uterine activity. These algorithms have been developed by the World Health Organization and are based on the latest scientific evidence. They can also be used for updating the clinical protocols you use in your department. This presentation explains how to review the caesarean section indications. This activity is also called a caesarean audit. This approach must be implemented by a team and not by one person alone. To conduct this audit, you can surround yourself with motivated colleagues from your department and form what is known as an audit committee. It is always useful to include a representative or your hospital administration in this committee to help implement solutions to the problem you will identify. The caesarean audit aims to improve the quality of care in your department in a caring, non-punitive way. The exercise is based on the self-assessment of your own practices. The audit cycle consists of 6 steps. First, classify the women who give birth in your department according to the 10 groups defined by Robson. Then identify the cases of caesarean sections performed among low-risk women, those belonging to group 1 to 4 of the Robson classification, and whose conditions are a priori favorable for vaginal birth. Third, collect the medical data among the selected cases. Then analyze the relevance or appropriateness of the indication for each caesarean section. Then issue recommendations to avoid a caesarean section in a similar clinical situation if the indication has been judged to be irrelevant. Finally, evaluate the implementation of this recommendation. Let us now look at each of these steps in detail. The Robson's classification allows you to classify women who deliver in your department according to their characteristics such as parity, previous caesarean section, onset of labor, gestational age, fetus presentation lie, and number of fetuses. The implementation of this classification has been presented in another video which is available on our website. The second step of the audit is to select the medical records for groups 1 to 4 of the Robson classification. For hospitals performing less than 20 caesarean sections per month, all caesarean section cases in group 1 to 4 can be audited. For hospitals performing more than 20 caesarean sections per month in group 1 to 4, it is best to select no more than 20 cases per month to avoid discouraging your audit committee members. You can do this by randomly selecting a sample of caesarean section performed before and after the onset of labor. The third step of the audit is to collect the data from the medical records. The QUALI-DEC project team has developed a questionnaire to guide you in this task. It will allow you to collect key information about the patient and her baby, the management of pregnancy and labor, and the education of caesarean section. Once this data has been collected, the audit committee members review the appropriateness of each caesarean section indication by comparing the information collected in the medical record with the standard of care. To do this, the reviewers select the clinical protocol that corresponds to the clinical situations of the case to be audited. In the event that no clinical protocol is available for a specific indication, the committee will assess the appropriateness of the Caesarean section according to its own expertise. For example, a Caesarean section was performed for prolonged labor. This 23-year-old woman had never given birth before. She was admitted to the maternity ward at 4 in the morning after rupturing the membranes. This was a single pregnancy in cephalic presentation. The uterus was contracting every 10 minutes, the cervix was dilated to 5 cm, and the fetal heart rate was okay. At 6 am, the situation had still not changed. The midwife therefore decided to start oxytocin per local protocol. 2 hours later, the uterine contractions had accelerated and the cervix was dilated to 7 cm. The shift change took place at 8 o'clock in the morning. 2 hours later, the dilatation of the cervix had not changed, according to the new midwife examination. According to the medical record, the patient had 2 uterine contractions every 10 minutes. The oxytocin flow rate had not changed since the start of the infusion. The fetal heart rate remained satisfactory. When cervical dilatation stopped again, the midwife referred the patient to the obstetrician on call. He decided to perform a Caesarean section for lack of progress. To analyze the appropriateness of this Caesarean indication, we will use the WHO algorithm entitled Suspected Slow Progress of Active First Stage of Labor. Using the information extracted from the medical record and following the branches of the algorithm, we find that the first midwife correctly diagnosed uterine hypoactivity. On admission, the patient was in active labor with a cephalic presentation. Cervical dilatation was not progressing normally for the first 2 hours. Uterine contractions were also insufficient. Clearly, this patient had a slow progression of labor due to inadequate uterine activity. In order to determine whether the management of this uterine hypoactivity was optimal, reference must be made to a second algorithm that describes the management of this complication. Following the branches of this algorithm, the decision for Caesarean section was made too early, even before the oxytocin infusion was accelerated to treat the persistent uterine hypoactivity. Before the infusion was started, the patient had no signs of uterine rupture, a diagnosis that should be considered when cervical dilatation stops. In view of the abnormal uterine activity, membranes already ruptured, and normal fetal heart rate, the midwife started the oxytocin infusion. Despite this, uterine activity remained insufficient. A Caesarean section was decided at this stage. Also, the rate of infusion should have been accelerated. It can therefore be concluded that this Caesarean section was potentially avoidable due to the non-compliance with the clinical protocol. At this stage, the audit committee should find local solution to avoid a Caesarean section if a similar situation arises in the future. In this example, action should be taken to better treat uterine hypoactivity. Training of midwives in the use of oxytocin may be necessary. Each recommendation should be well defined and clear, measurable with specific criteria, realistic and achievable with a clearly defined timeline. When the 20 medical records have been analyzed by the audit committee, it is important to inform the whole maternity team of the result of this evaluation in order to raise awareness among colleagues and to generate changes in the organization and attitudes of all. This can be done at a team meeting where the results are presented by the audit committee and discussed with all members of the department. It will be very useful to invite one or more representatives of the hospital administration to this meeting to facilitate the mobilization of resources. On the basis of these results, an action plan will be adopted, identifying the key actors and guidelines for implementation of the recommendation. The implementation of this action plan will be evaluated at the next meeting. Participants will identify the reason for non-implementation and solutions to facilitate. They will set up a new action plan if needed. Caesarean audits has been tested in different contexts, as in Canada, China, and Burkina Faso. There is a clear benefit to implement Caesarean audit in healthcare facilities. It has reduced unnecessary Caesarean section without negative effects on maternal and perinatal outcomes. I encourage you to visit our QUALI-DEC website. You will find the different tools presented here and the results of our ongoing studies.